All right. Well, thank you. Thank you so much for staying with us to this last session, and we're going to get started right now. So if you want to make your way to your seats, we'd appreciate that. And looking forward to this conversation. I think we're hoping that this will sort of capture the essence of why we're doing this work, which is change and quality improvement. We're making constant changes. We're adapting, we're improving, and some changes we don't like, we abandon them, and changes we like, we expand it. But we also know the power of advocacy, and we'll talk about that for the next hour as we wrap up our learning session today. But I'm going to let my panelists introduce themselves, and I'll start with you, Francesco. I know folks got a chance to meet you yesterday, but just...
Okay, Francesco Vendrame.
Tell us something fun about yourself.
Tell something?
Something fun, something that others might not know. I'm like, wow, that's so cool. Tell us something really cool about you.
That's something very cool. Well, for kids, avid fisherman, and this is
a fisherman.
Yes.
Yeah,
fisherman. Yes.
Yeah, okay, that is cool. That's cool. Yeah, like salmon and all kind of fish.
Well, salt water and let's say river fishing, and Miami is a very nice place for this. You can the Everglades, and you can have a lot of action and fun.
Man, my list keeps growing on stuff. I need to add that onto the list of more things to do in Miami. Thank you. How about you, Janine? Tell us. I know we met you yesterday too. You're one of our host PIs, but tell us something fun about yourself.
I like to bike ride on the weekends.
That's cool. That's cool. What's the longest stretch of bike rides you've done?
Oh, no, we bike ride to lunch, eat lunch, and bike ride back.
Oh, that kind of bike ride.
That's the fun part.
It's the touch that counts. That kind of bike ride. How about you, Laurel? So, Laurel, let's get a chance to meet you. Some of the folks in the room might not know who you are, but if you can introduce yourself, and then after introducing yourself, you can tell us something fun about you.
Okay, well, hi, I'm Laurel Koester. I'm from the Helmsley Charitable Trust. I first wanted to say a big thank you to the T1D Exchange for organizing such a lovely meeting, and what a stellar lineup of people. I really enjoyed seeing familiar faces and getting to meet new people. So I really appreciate everyone's time and enthusiasm and all the work that you do. So fun fact about me, during the pandemic, my husband and I inherited a catfish named Walter from our neighbors who lived upstairs.
Wow, okay. That is so cool.
Walter is now in Central Park in a pond.
Wow. Well, thanks for sharing that, Laura. Really glad you're here. And she's been, and the Helmsley Charitable Trust, we can overexpress how grateful we are for their support. So we appreciate it. And a lot of really cool stuff happening at Helmsley, and she'll share some of that today. And hopefully opportunities for you all to be able to re-engage with all of the advocacy efforts Helmsley is leading nationally. All right, Amanda, I got a chance to meet you, but tell us about yourself and tell us about some of the special guests in the audience as well afterwards.
Hi, everyone. My name is Amanda, and I was invited here because I am a parent of a type 1 diabetic. Her name is Coco. She's over there.
Hi, Coco. Can we wave to her? Yeah.
She's like, Mommy, your picture. And this is my first time speaking publicly about diabetes. I'm also married to a type 1 diabetic, and my mother-in-law works for Dr. Sanchez. So we really have the diabetes dream team.
Totally. Well, thanks for being here, and we appreciate it. And looking forward to conversations with Amanda, because Amanda would share perspectives from advocating for a child with diabetes, also advocating for an adult with diabetes, with advocating for a husband as well. So we're looking forward to hearing more of what you're going to share with us today. And then finally, Ori, tell us about about yourself.
Fact, in my free time, I enjoy dancing and listening to good music. So that's probably no one knows about me.
You guys know what I'm tempted to ask. I'll save that. I'll save that. All right. So I think I want to sort of start with you, Amanda, with that question, and if you can sort of help us walk us through the journey. If there's a story you want to share on what it's like to advocate for a child with diabetes, and what it's like to advocate for an adult with diabetes. Do you see any differences? Are there similarities? We're curious to get your perspective on that.
Sure. My husband and I have been married for almost 10 years, together for about 15, but he really didn't involve me much in his diabetes. He was diagnosed when he was 13. It was a private thing, mostly. And then when my daughter was diagnosed last December, it changed a lot in our house. He was forced to talk to me about it. I heard him on the phone, like fighting with insurance, fighting with US Med, like trying to get the medications he needs. Then I got a taste of that myself. But I think we really struggled the most with education and childcare. So my daughter's been in like a daycare situation since she was 14 months old. We went after diagnosis, we had to like let them know what was going on, and we had to talk to them about her care plan and how to take care of her now. And the school was completely overwhelmed. They refused, really. They refused to give her insulin. I had to go there every day at lunch to give her insulin. They refused to prick her finger. And they then demanded that my husband and I find and pay for a full-time aide for her, which didn't happen. She's in a much better place now, but it was really stressful, like two working parents trying to figure it out. I mean, thank God I had a ton of flexibility with my job. I was able to scoot over there at lunch. I don't know what we would have done otherwise. And I feel for all the parents who like don't have that kind of flexibility. Like, what do? Your child's already gone through so much change. And then like to add like, oh, and you're also getting a new school, or you're staying home with this new babysitter, or, just like more disruption in their life. So I'd love to see some changes when it comes to like childcare and making sure kids like can get the care they need while at school.
Thank you. Thank you for sharing that. And Laura, if I can turn to you, I know Hemsley is doing remarkable amount of things in the advocacy space to really move the needle on type 1 nationally. Can you share a little bit of that with us, and what sort of initiatives are you very excited about as well?
Sure, I'm happy to. So I will start by saying, so as a private foundation, Helmsley, we have certain restrictions. So for example, we cannot lobby. We tend to play it pretty conservative around that. But so the way that we advocate is we fund data generation. And we fund that in two ways. There's there's indirect and kind of direct ways that we fund data. The T1D exchange is an example of more of an indirect way, because we have funded essentially the infrastructure for the quality improvement platform that is now kind of the largest data set on type 1 in the US. And that's an enormously powerful tool to advocate for change. Then some of the more direct work that we fund. So we have kind of a few categories of things that we're quite interested in. One is, we know there are not enough specialists in the US. So we're really focused on, for example, school nurses, pharmacists, primary care providers, and how we can support them in practicing at the top of their license. So we have several projects that are related to that type of work. And by the way, I'm happy if anyone would like more information on any of these projects, I'm happy, come find me afterwards and I'd be glad to give you details. The other kind of category of projects that we're also funding is, we've talked a lot about device use here and the equity piece of it. We're very focused on increasing access to CGM through Medicaid specifically, because we know the data shows that there are distinct inequities by insurance type. So we recently funded an environmental scan with the Center for Healthcare Strategies to look at the landscape of Medicaid coverage of CGM, and we're now embarking on a follow-on project. And I've had many great conversations during this meeting about, I think, interesting and impactful work that you all have done within your own states to move the needle on CGM coverage. And then lastly, I think one thing I want to highlight is measures beyond A1C is something that we are extremely passionate about. So a big effort that we've embarked on is working with the National Committee for Quality Assurance, or NCQA, to develop measures that would be derived from CGM related data. And so the goal would be for them to be included alongside A1C, or even in lieu of A1C, as well as behavioral metrics. So those are some things that I'm quite excited about, and I think have a potential to make a huge impact. And we would benefit from working with sites and leveraging the data from the exchange.
Thank you for that. And then for Janine and Francesco, I'd love for both of you to weigh in on this question. You know, from your perspective as providers, peds, adults, what are some of those barriers for you to be advocates for your patients, to be advocates for change locally? So can you share just, a few of the barriers? And Janine, if you want to start.
I mean, cost is obviously the biggest barrier. Trying to get our patients, for example, we moved so we work in a public hospital, but we're a private university, and we got the university to just bring all the patients in, no matter who they are, what their funding is. But that the university had agreed to give up that cost to basically see patients for free. Having the number of patients that we have that are unfunded, that's a big thing. Just getting their diabetes supplies. Diabetes is such an expensive illness, as everybody knows. So just to be able to advocate to get the supplies, to get somebody to cover that, to find a way to do that, I think that's one of the biggest problems.
And I think from the adult perspective, is very similar. Access to medication, access to, I would say, technology. All this data we have over and over really show how technology really makes a difference in the treatment of this condition. But actually, in many times actually, the problem is that have the patient to be able to access that. So reaching legislators, that I think is something we'd like to talk about, plays a key role, but it requires also specific skills and understanding how things work. I know the House of Representatives recently passed the Affordable Insulin Act now Act, and this is going to be further discussed on the Senate. And what this will result is that put a price cap of $35 for insulin. So again, there are authorities, right, and a lot of initiatives that work on that. Our role is try to reach them.
Thank you. And so I want to segue to successful examples of advocacy efforts. And maybe I can start with you, Ori. I know you are doing a lot of work with sites, with QI coaching and with the Health Equity Project. Are there examples on, how centers have been able to advocate for change locally in their center? One or two examples you can share?
Yes. So for the equity pilots, we've had, there's so many examples I can share, but one of the centers that participated in the pilot was really able to bypass the pump committee. So before the project, they had a pump committee that would decide, when a patient gets a pump. So if a patient has an A1C greater than 9, that kind of patient wouldn't be able to get a pump. But, with the project and the conversations and just even trying to let's just test, let's just see if this is going to work. They were able to meet with the committee, let them know that let's just, try this, maybe with 2 patients, with 5 patients. And now, that no longer exists. The pump committee no longer exists, which is great. Another example is the fact that I think 2 of the centers that participated in this pilot now have a license to be a DME pharmacy, because we know that there's, a lot of barriers with insurance. So I think that's also a big deal. And I know that a lot of other sites are probably trying to get that license. So.
Thank you. Any other success story, any examples from anyone? Go for it.
I will offer a couple of success stories
Yeah.
I heard while I was here on the topic of CGM coverage. I was in one of the breakout sessions yesterday, and I heard from our friends, I believe, at Barbara Davis Center and Nationwide, that you all had been able to move the needle on actually updating coverage requirements around CGM. And there's resources that are available potentially for other centers to be able to leverage. So I was very excited to hear about that. And I think it's just a wonderful example of, one, it is possible to make change, and there are resources for other sites to be able to leverage.
Yeah, so Amanda, I want to start with you with this question, and Janine and Francesco, I'd love for both of you to weigh in as well. The topic around transition from peds to adults, and and why I want to start with you, sort of the unique situation you're in with your husband and your daughter. Like, so do you have any sort of thoughts on doubts? What are you thinking about now? What sort of things is coming to mind now? And if there are examples too from your husband's story that you'd be willing to share on, how was that transition for him that you might have heard or seen? But more importantly, what would you like the health system to do better to really help move pediatric patients with type 1 into adult type 1 that are also thriving? And also love to get both of your thoughts too on that question.
Still figuring it out. I'll tell a funny story though. We have good friends. Oh, sorry, I think I just sprayed you. My water. And we often do date night. The dad husband, they have 2 little kids as well. The dad husband has type 1. He was diagnosed when he was 6. And we all went out to dinner, we're drinking, we're eating. And I was like, so, when did you guys manage your diabetes, start to manage your diabetes on your own? And at the same time, they both said college. And I was like, no, that can't be true. And they were laughing, and I was, but I think because of the technology, I don't know, maybe I'm naive, but I'm like, by the time she's in kindergarten, 1st grade, I'm hoping she's can feel the low and can grab something from her backpack. Right now, it's so disruptive. The phone goes off, then they have to walkie-talkie the nurse, then they have to take her out of the classroom. I mean, she's spending legit for every single low. I mean, she's out of the classroom for at least half an hour, 45 minutes. And I'm always send her back to class. She needs to go back to class. So anyway, I hope that she can become more independent a lot sooner because the technology.
No, thank you. And then do you want to start on that transition topic? And
so the technology actually makes it interesting, because in some ways it's an easier transition that the parents can still be monitoring and seeing what's going on. Some of the pumps you can monitor, as well as the sensor. But that's also another step for the kids to have to monitor and have to learn how to put on and have to know how to order and have to get. So I think that's something that it's much more complex. Ordering supplies is more complex than before. So it's something that we're trying to start with earlier. We actually have a questionnaire where the patients have to start filling out when they're 17, do you know where your supplies come from? How do you get them? Do you know how to make an appointment? Do you know where you make an appointment? Do you know where you go for your appointments? And just starting to work with that. And we used to transition back in the day, in the mid-20s, when they were 22, 23. And it was actually more of a problem because they were coming to visits on their own, but they didn't really know how to do everything. Then we started transitioning at 18. And in some ways, it actually worked better because the parents were still involved and kind of made sure they got to that first appointment, that they had that connection. So we've actually left it at a little bit earlier transition time while the parents kind of help that initial smooth time. And then we're fortunate because we do have the adult team that we work very closely with. So it has been usually a fairly good transition over to them. You know, we're not hunting down people usually to see our patients.
Lately, you are hunting
Yeah,
down.
we are, but
No, a very relevant topic. I have to say that from the adult perspective, there is so much that can be done, and we are not always able and prepared to do it because overall the reality of an adult endocrinology clinic is mostly focused on patients with type 2 diabetes because we need to face the way it is. And there is a general lack of resources to be able to do everything that we should. In our specific case, I have to say, we are a little bit deficient in being able really to create a path that can make the transition easier. But I have to say, pediatrics does in our system, pediatrics does an excellent job in preparing the patient. And so this makes in our case, much more smoother.
I think there were a lot of conversations today around like advocating for more resources and funding and support for patients that might not have insurance, or patients that might not be on CGM, or and also even thinking about insurance, sort of that space around insurance advocacy and working with insurance to get something you need. So if any of you can sort of speak a little bit more on that, on with specific groups, what does being a strong advocate, what does that look like? And if there's an example you can share, because I feel that people might benefit from some of those.
we had to fight with the state of Florida for a while to get sensors covered. And even back in the day, just to allow people to check their sugar more than 5 times a day, or they would only pay for 3 pen needles a day. So there was a lot of fights that we had with the state coverage. Now, fortunately, we're in pretty good shape, but we had a lot of phone calls, a lot of letter writing to be like, this doesn't make any sense. You guys are trying to save a dime by only giving 3 pen needles. Now they're going to go into DKA because they can't take an extra shot. And so that took a while to find who are the powers to speak to that can make that change. And then it becomes with insurance, the same kind of thing. Like, who do you need to speak to? And getting the patients to be their own advocates with insurance helps a lot too.
I've had amazing success with Aetna. I've heard from friends who have other carriers, and they've really struggled getting their supplies covered. But I don't know. I think it's all the work that you guys have been doing over the years, because we've just been really, really fortunate. Coco was approved for Omnipod 5, and the supplies were at my house the next day. Like, it was incredible. No issues getting CGM covered. I just ordered Gvoke because ours expired, as the school nurse reminded me, or is about to expire. They're like really on top of their stuff. And so I had to order another one, and it was $25. And I remember the first time, like a year ago, when I went to pick that up, it was several hundred, and I was like, I need a coupon. So yeah, I was shocked. I've noticed like a huge change. And my husband, I mean, there were like weeks when he would go without a Dexcom because we were waiting for insurance to approve it. I mean, we haven't had that issue in the last year.
Yeah, and I'll say that you're lucky, you're on private insurance, and that's, very common that patients on private insurance are able to get these devices quicker than patients on public insurance. The other day I was speaking with someone, and he has no diabetes, but he told me that he just told his provider he wanted the CGM, and he got it. And that really got me thinking that, there's a lot of people with privileges. He said he just wanted to know how his blood sugar was doing, and there are tons of people that, really need this device that, have no access to it. And at the T1D exchange, we've supported centers, with writing letters to the state Medicaid for coverage. And I know that even New York, they cover like CGM and all, but there's still a lot of requirements, like you have to do it quarterly. And, they want to be able to do it maybe twice in the year or just even annually. So we support that as well at T1D Exchange.
And then Laura, if you can take this question, and others, please feel free to jump in. What sort of resources are sort of available for people to think about? And, are there resources that you found helpful as you, in your role to, and working with all of the different grantees, working with people working on numerous projects? I know Helmsley funds quite a number of interesting projects in this space. So if you can sort of share or give us sort of an overview on some of those resources that others should be aware of.
Yes, I would be happy to. And I think if I can make a plug, maybe some of these resources can be included in the Quality Times or another avenue.
We'll do that. Once your funder says do something, we'll do it. Yes. We're on it.
Just so everyone can get them. So, I mean, the first thing I thought of was just connecting with other centers here. I gave the example of, the CGM coverage success and being able to leverage those type of resources from other centers. There's no reason to reinvent the wheel. And I think another thing that's quite important just in terms of advice, and then I will get to resources, is really connecting with the key stakeholders and thought partners, from the very beginning. And that includes, to the extent possible, payers, especially Medicaid folks. I think wrapping them in from the beginning to the extent possible so that they're part of the process. I know with anecdotes from some other grantees, we've seen success with moving the needle on coverage. Also, professional associations, Helmsley works very closely with JDRF, ADCES, ADA, and I would also say, don't forget primary care. Helmsley's in the process of exploring how we can make more inroads in primary care. And so state primary care associations have been raised as a vehicle. They're doing a lot of advocacy themselves. So potentially even thinking about partnerships with primary care. Also, if we're talking about Medicaid, in my deep dive rabbit hole that I've been going down lately with Medicaid and CGM is, many states are managed care states. And so there are ways through Medicaid managed care contracts, requirements related to equity, for example, social determinants of health. And so finding ways to align, I think, what data you can share in a way that aligns with, for example, things that are in contracts is potentially a way forward. And then resources. So we have, I mentioned several buckets of projects related to pharmacy, CGM, measures beyond A1C, and there are resource papers that have been developed through grants on all of those topics, and we can share out links to them. We also, so ADCES, or the Association of Diabetes Care and Education Specialists, surprised that I got that. We funded through them. They have a CGM coverage tracker, which leverages data from a platform called Policy Reporter. I believe it's freely available online. And so it has basically the coverage requirements by state for CGMs. We also, we support a website called Diabetes Wise and Diabetes Wise Professional. And in 2023, Diabetes Wise Professional, so there's a whole suite of prescription resources to help with devices. And there will be data that is going to be imported from Policy Reporter that I just mentioned for across all 50 states, all major devices, commercial and public insurance. So we've heard that's a big pain point, that nothing's in one place. And so we're very hopeful that that will prove to be a helpful resource, and we encourage feedback once it's available. One more thing.
Please, please. You can do 3 more.
So so Helmsley works with a consultant health management associates. And recently, so they've been helping us figure out kind of just issues within the telehealth landscape that we should kind of be thinking about, what might be coming down the pike in terms of reimbursement with the public health emergency. And recently they hosted a webinar for us. Many of you might have been on there. There's a recording, if not. And in 2023, they'll be hosting another webinar. And I think one of the key topics will be talking about the physician fee schedule and kind of implications for diabetes care moving forward. So that's another resource that at least our team has found helpful, and we hope everyone can benefit from it too.
That's a very comprehensive list, and yes, we'll add it to quality times. I'm looking at Holly. Holly, please, quality times. All right, Uri, please share.
And our data is a big resource that we have. The data is not just the numbers, it's really what kind of story can we tell with this data. So we have the QI portal, which, if you're mapped, you can, access the data that you can you'll be able to filter your data by race and by ethnicity, because that's really, how we want you to start thinking about your data. How are the minority patients doing compared to, other patients? And I think another resource that we should be thinking about is our patients. We've heard a lot about providers, saying that patients' preference is like super important to them. So we need to capture their preference, by bringing them to the table, and also helping them to be able to advocate for themselves. And lastly, I think it's important for us to begin to see the T1D exchange itself as a resource. Recently we've been hearing a lot about the glucose pricing, and the fact that a lot of sites are beginning to say that they don't want to use glucose, that kind of thing. We are now in the preliminary stages of really talking to stakeholders about how we can help. So really looking at the exchange itself as a resource is something really powerful.
Amanda, you want to add to that?
I signed my husband up. I also signed my daughter up before I even knew about this conference. I heard about it through a podcast. And I think it's amazing anything we can do to help improve the lives of people living with T1D.
Thank you. And Amanda is talking about the T1D exchange registry, which all of your patients can be a part of as well. So it gives them a chance to be involved in research and sort of get an opportunity to participate in that. Janine, any resources you found really helpful?
One of the other things that we've done is go back to industry and say, you want me to prescribe your pumps and your sensors? You need my help. I need your help to get my patients on it. So they sometimes have the money to do the lobbying and to get these coverages. So we'll keep reminding them, I can't write that prescription if none of my Medicaid patients can get that. And so they'll go to a lot of the managed care companies. So I find it's good to talk to the reps and get them to, help you do that. And some of them will have form letters so you're not having to rewrite a whole form letter for the Omnipod 5 now, or the Dexcom 7 when it comes out, that, okay, give me your form letter and we can send it out. So I find it helps. They have the funding for that.
Well, I think one of the talks early today was about that was team science, but I think we should translate that also in an area for reaching the legislators, meaning that there are a lot of initiatives out there, and one of the possibilities, get all together, and a lot of those different organizations join together. Helmsley, right, with the JDRF, they have several collaborations, but there are other initiatives. For example, one is the Patient Pocket Protector Coalition, for example. This is for patients that can have any kind of chronic disease, but have issues in terms of afford medications. And and the list can keep going because there are others. So again, rather than playing along, right, team up.
That's really good. That's really good. All right, I'm going to turn it over to you all to get your questions. Questions. Oh, I see them. Okay, so Sam is going to walk around the room, and we have time for questions. So Sam.
Thank you. I'm going to start with a virtual question. Do you know how much research has been done based on children when they've missed class time? What was mentioned a little bit earlier, leaving classroom due to highs and lows. As they can imagine, it's probably very disruptive.
I've not seen that. That's actually a great research question. I've not seen that.
We're going to turn that question back to the audience. Is anyone aware of study looking at that specific question? Manuel?
I haven't come across a study, but we've talked about it at this platform that on the should we have that question of how many missed school days? We talked about it, but then ran into concerns like Todd was saying earlier. Hey, what does that mean? Are we listening to the mom? Are we listening to the kid? Are we going by documented school attendance or something like that? And I think it kind of got dropped there somewhere.
I think it's two different questions. I think it's actually the missed day and then the missed hours, the missed time because you're pulled out of class versus I didn't go to school at all. I think it'd be interesting.
I think that's a really Coco, you have some thoughts? You have something you want to share with us? And for those virtually, Coco is so cute. Coco, no, okay. Later we'll come back. We'll come back.
She looks a lot bigger than she is. She looks a lot older, but she's only 4.
We'll come back, Coco. So I do think that's a great idea. And if there are PIs interested in that topics, reach out to Shivani or Shida and let them know you're interested in that topic.
Great question for the type 1D, the exchange for the parents to answer. Do a survey on the parents to answer.
I know our school nurses, they log everything.
Okay.
They're very detail oriented because they have to call me and report back. And so, yeah, I'd love to share that information. And
It's a great idea, And please go ahead, Laura.
So I wanted to share on this topic. So we've been trying to establish a relationship with the National Association of School Nurses. I was made aware, maybe you all might know already, but they have a data set that they're collecting. Is called, I believe, Every Student Counts. So they do it. It's not the best data, but one of our ideas moving forward is can more robust data be collected on students with type 1 kind of as a demonstration case, almost like building the infrastructure with the T1D exchange to be able to have a more representative kind of data set on what T1D is like in the school setting, which could include, being in your seat, missed class hours, etc. We also are funding a project with Avera Health. It's a demonstration project, and it's looking at a virtual school nursing model. And so some of those types of metrics around, school attendance are going to be included in that study. So it's a bit of a different take, but hopefully it will be useful.
Yeah, so good.
I just want to go on to the school thing. Oh, hi. Okay, hi. So I'm in New York City, and we actually had started a group with all the different, like NYU, Monty. We have like an NP-led group that works with the Department of Health because we had so many issues. There was a lawsuit in the school. But what came out of it is when we spoke to them this year, there's a new head of the diabetes program who used to be attending, I think, at Monty, was originally at Yale, who's lovely. But she was like, I have so much data because I'm from the school forums. And she's talked about, she's like, I'm sitting in a data, I'm just saying, Helmsley Trust in New York City, that might be a contact y'all want, because she's like, we have A1Cs, we have how, the kids, the amount of kids who are supervised versus not. Like, she's like, I'm sitting on a data mine. She kept telling us this, and we were like, huh. So
Yes, please.
that might be I could reach out with her name.
We love it. Love it. And I think Dave, and then we'll come back to you, Lily, if you don't mind.
Yeah, just one project I'm aware of that somebody contacted us about from a company looking at the humanistic burden of type 1 and severe hypoglycemia. And they have 3 groups of people, parents of kids, but also adults who are taking care of elderly adults with type 1 as one of the groups. And they're really trying to quantify absenteeism, productivity, you know, all they call it the humanistic burden of what, you know, the severe hypos are doing to caregivers. So we're going to help recruit people into that because they're having trouble finding those people. So we're trying to work through our registry of like relatives and so forth to get there. But we're looking forward to seeing that work.
Thank you.
I don't know the cutoff for them. Me and above, I don't know.
So I just want to say for Amanda and the other parents, one of my little guys with diabetes, his mother and we worked together. So on the school form, we emphasize that the care of the child needs to be in his native environment and not be removed from the classroom. So we have the LVN aide come to his recess area, to his lunch area. So he's not waiting in the office for 15 minutes until the nurse is available. When he has a low, he's treated in class. So that avoids him missing classroom time. So it's a difficult push, and I'm sure we're going to get pushback, but I guess if we don't push, we're not going to get what we want.
That's amazing.
And after a question, I do also want to hear some success stories of advocacy efforts from the group. So if there are other success stories you all have had, please let us know so we can capture this as well. But go ahead.
That's actually what I was going to pivot to. This is a very, very small scale, but turned out to be a great outcome. So I found out the Ohio Medicaid Committee on Pharmacy and Pharmacotherapeutics was meeting, and they were discussing what medications to include on their formulary. And up for discussion were various glucagon agents. And at the time, Ohio Medicaid plans did not have all the available options on their formulary. So I put together a presentation and I attended their committee. And I was actually the only person that talked about some of the glucagon options and why it's important to have a variety and why they all need to be on formulary. And at the end of it, I literally got the response, "Oh, wow, this sounds good." And they approved it. So we have all of our glucagon options approved for Ohio Medicaid plans. And that was not an intention. I thought, oh, I'll just contribute the little thoughts I know and hope it helps. But you can actually show up to something and really be the content expert. And we're all content experts in this room. And just that one voice can really, really make a huge difference. So don't ever underestimate your power for change.
That's really beautiful. Thank you.
I want to just comment on glucagon. New York State just changed their law to say that to cover glucagon administration instead of glucagon injection. So in your states, if the state law has the word injection, you may not be able to put Baqsimi in a school. So you may want to look into that. It's an easy change, but it was important.
Hi, Mary Lauren Scott from UAB in Alabama. The paper that Jessica Schmidt published from our group last year on the CGM uptake was only really possible because of advocacy to Medicaid, and Medicaid in Alabama did not cover CGM until 2019. And so our group got together and wrote a letter and talked to the Medicaid coordinator that's at our hospital, and they were able to push for that successful change, which really helped with equity and use in our patients. And then recently, I was able to get a little win with industry. We mentioned an idea we had for a QI project that will be probably coming forth in the next year to Medtronic directly, and told them that we wanted to do more work with the smart pens, but that we didn't feel comfortable doing it until it could be equitable with our patients, and that we needed a way to get it through for our Medicaid patients that was easier and at a pharmacy near our hospital. Prior to that, it was at one mail order Walgreens specialty pharmacy in the state and 10, 15 miles away from where we were. So then we weren't able to start it inpatient, et cetera. And so they were able to partner and work with the outpatient pharmacy at our hospital. And they are putting some resources into it, but they I don't know how many centers they can afford to do this with right now, but moving forward, there's some momentum going for us to be able to do that the company has provided, which is nice.
So I'm gonna put a plug in for what we've been able to do as a success story. So Dr. Gandhi's here, one of our other faculty members, Aurelia Wood. So both of them over the last, you start pre-COVID, 2021, and they've been able to implement a school health program. Now, the sad part was they took our staff and my diabetes educators went over there, but I'm going to let her share a little 2-minute story with that.
Hi, everybody. Yeah, she put me on the spot, but I was going to say something anyway. So we created this, we had this dream during COVID about the struggles with school and healthcare and the frustrations that our families had. So back in 2020, we actually partnered, Dr. Wood and I, who's another colleague at Nationwide Children's, we sat down and said, how do we fix this? And as you know, all our departments have no money. So nationwide, we were blessed to find out that if you don't have money, you find someone else in the institution that may have money. And so we were lucky enough to find a department. We have a growing department called the Department of Community Wellness at Nationwide Children's, and they help foster the number of growing school health programs in our hospital. And so we have a very successful 20-year school-based asthma program. And so we modeled and created a business plan during COVID for a diabetes, it's called Diabetes and School Health DASH program. And we created the business plan, we presented it to leadership, and like 18 hours later, they said, yeah, you can have your $250,000. Wow. They said, this is awesome. So, I mean, it was with all the data showing that, you know, missed school days, but it was more anecdotal than the systematic data that we don't have. So we have an advanced practitioner that we did steal from Endo, but sorry. And then 2 diabetes nurse educators with a 5-year plan to grow. And they go to the school health. We have a diabetes composite score that we created for high-risk patients based on the diabetes care that they have. And so the patients with the lowest scores were the ones recruited into this program in the first pilot year. And they go our team goes every month to these schools in Central Ohio and provides care, provides diabetes nurse education and quarterly assessments with the parents. So go where the families are because they're not coming to clinic. So we did this, and right now we have 75 patients enrolled. We have a long waiting list because the nurses now found out about it, and they're like, we want everyone in this program. We don't have the staff, but we hope to grow. And so we go to 53 schools, 12 school districts, and we have 75 students. And our diabetes technology has doubled because honestly, you know, the struggle with these high-risk patients, we say, well, they can't be on diabetes technology because we worry about them. They don't show up to clinic and we don't know how to follow up with them. Our diabetes team is going there every month. That's the best plan. So of course, we're going to put them on a technology and figure this out. So we try to put everybody on a CGM and a pump. And these are high-risk patients. So we're hopefully going to see some acute care utilization drop. So we're still in our 2nd year, so we're still learning, but we're hoping to maybe get some data. We're getting data, qualitative survey data on the school health, nurse competencies. We're getting burnout rates for school nurses. We're getting all of our medical data, of course. And then we're hoping that maybe we can get school missed days. We haven't figured that out yet either. So
I'm sure our nurses have had a few panic attacks. just because it's very stressful, right? And they're not allowed to follow her. So they're just like reacting when the alarms go off, and it can be really stressful. And I'm so grateful for them. And I wish they neither one had ever used Dexcom before or the pump. They were trained like some old school methods. And so, yeah, it's a huge need. I hope it comes to Florida.
Yeah, well, if we get enough money. But I did want to share one story. I guess when we created this program, we found out a lot more than we probably ever would have from the clinic. And our nurse practitioners and our diabetes team kept coming back to us. Every day was like a whole story about what they found out, what was going on in the schools. I'll tell you one story real quick. They were there for another patient that was enrolled in our clinic, and they were in the nurse's office. It's nurse school lunchtime, so there's a bunch of kids there. Some kids were sick, some kids were, and then there was one diabetes patient that was not ours, probably followed in our clinic, but I'm not totally sure, was sitting, she was like preteen, girl sitting with her friend because they were about to go to lunch. And she said, oh yeah, well, they were both diabetes. One of them was in the 60s and dropping. And my staff was noticing it because they were just with our patient. She's like, oh, well, I'm 60s, but the nurse told me I could just take my insulin and just go to lunch. Okay. The second kid said, well, the nurse said I could just stay in the 200s, so I don't have to miss class. Okay, got it. So she called us, the nurse practitioner, because this is our pilot year. So we're like, if there's any issues, medical issues, let us know. So we get a call, Dr. Wood and I get a call. She's like, what should we do? They're not legally our patient, like we're not supposed to intervene. But I was like, no, go talk to the nurse. It's okay, we'll figure it out. And so then, so those kinds of stories, she's like, no, honey, why don't you just not take that insulin just yet? Why don't you take something else? And it was a busy nurse. Of course, it's a school health. She was a great nurse, but it was busy, and she may or may not have known exactly what to do. I'm not fully sure. So those stories kept coming out for a whole year. But we're grateful that we're there, and I'm hoping that we can create this infrastructure for other maybe programs to do it. But we were grateful for other departments in the institution that helped us do this program from a broader perspective. So from a community perspective.
Thank you. Thank you for sharing that. I had to believe you didn't want to see anything before Kijao. But I think we're going to wrap up here, and just to summarize some of the main themes I've heard today. One is we all advocate for change. We all have the power to do something, even if it's a story to share, even if it's showing up at a meeting, even if it's sharing a perspective, we can do things. There are tons of great resources, and bringing our parents and patients, people living with type 1 diabetes on the table to be a part of those conversations. Our roles as providers, we have a great role to play as advocates, as QI champions, as QI analysts, data scientists. But more importantly, I think even when we don't have all of the answers, we have a network of others that might be having the same struggle. So one is, can we bring our collective pains together to amplify that to folks that will be in the space to make decisions? Two, are there interesting data that can help us advocate for change better? So can we capture that data in a unique way? We have the power to do all that. And then we keep pushing, we keep striving, because we know that the work we want to do also has to happen outside of the clinic. So I really love all of the school nurses story. I love all of the examples happening with Medicaid, Medicare, and really sort of pushing that piece. So we hope you found one of those 2 tips helpful and really enjoyed having this conversation, and even the conversation on the floor, because that's really one of the uniqueness here is we're all experts and we all have 1 or 2 things to share on key topics. So thank you for being a part of this. And can we appreciate the panelists again one last time? And then Dave is just going to close us out as we wrap up our time. Safe travels, everyone. We appreciate you.